Hello everyone, we are very pleased to host you for this new Visionix webinar. So the today presentation will demonstrate the pivotal role of the Visionix VX650 in the success of the Estação, the Olho project, a mass eye screening initiative which aimed at improving access to eye care for underserved population in Rio de Janeiro in Brazil. By placing the VX650 at the core of its workflow, Estação do Olho is redefining how early detection and prevention of vision loss can be achieved on a large scale, highlighting the importance of innovative technology in public health. Let me introduce you Dr. Gustavo Novais, who led this program together with Dr. Bruno Fernandes. Dr. Novais is a professor and doctor in ophthalmology, specialist in cornea and external diseases at McGill University, Montreal, Canada. Dr. Novais, stage is yours.
Hi everyone, my name is Gustavo Novais. I'm an ophthalmologist from Brazil. I'm a cornea specialist and I'm a professor at the university. And first, I would like to thank Patricia, Lionel, and Fabiano for the invitation and all the crew from Visionix. It's a great pleasure to talk a little bit about this exciting project that I have developed with my partner Bruno Fernandes, and we're gonna show you how I use the VX 650 in this mass screening project here in Brazil. This is the why. When we take a look at the numbers, this is a Lancet article, and every time I look at this article, what gets my attention is this number. Almost 20% of the people that are considering blind or with severe visual impairment, they are so because they don't have simply eyeglasses to put in their faces. And that shows how unequal the health system is all over the world, and in Brazil is no different, unfortunately. We know that we lose a lot of money because of it's a huge burden for economics, and we know that about 2.2 billion people have visual impairment, and we know that about half of these patients of these cases they could have been prevented, and that leads to loss of productivity. We know that we lose a lot of money annually, around $410 billion every year. That's kind of equivalent of 0.3% of the GPD of a country. If we look at uncorrected refractive errors, we estimate that those alone are they are responsible for losses of about $200 billion every year. That's a huge loss for the governments. We know that the governments they spend 3 times more money treating problems than they could have prevented. So that's a lot of waste of money. So I think we could do better. In Brazil is no different. We know that about 1% of the population is considered blind or with severe visual impairment. In Brazil, only about 25% of the people have access to private healthcare system, and that leaves about 75% of the people depending, which is 160 million people, and they depend of the public health system, which it's in theory it's very good, but I know by experience because I've been working the public health system since I'm a professor. I went to medical school, and I know that people they get in, but they wait too long for their treatment, and I've seen a lot of patients going blind waiting for their treatment. That's a shame. And in Brazil, about 75% of the causes of blindness they are reversible, and most of them related to cataract and refractive errors. So that's a place where we can act, and if we are able to prevent, we can be more effective in treating those patients as we identify them. So, because of this why that this pain that I just showed you, we decided to come up with a project that combines prevention and accessibility with technology. And our goal is to impact in this numbers of blindness, so we can minimize the social economic impact of these eye diseases. And we are targeting the populations that I just saw, that I just told you guys, that are the unserved communities, which lacks access to healthcare and lacks access to education about eye care. For that, we developed this project and we are partnering with industry, pharmaceutical companies. We are trying to partner with government so we can reach out for more people and increase our screen stations so we can get early detection of the diseases and we can educate the population as well. So I'm going to be talking a little bit about how we do in daily basis. So this is the station that we have designed. It looks like an eye, and I think it's very neat. You can see the Visionix VX 650 over there. So basically it goes like this. It's located in a shopping mall because of security issues. So the patients, it's a free screening station, screening test, okay? So the patient, he goes there and he register, then he gets his visual acuity checked, and then he goes through the exam in the VX 650 machine. After that, he gets sent a report within 48 hours, telling that with a risk assessment, and we point out all the abnormal findings, and then we connect this patient with physicians, ophthalmologists in our platform. And by going to an ophthalmologist through our platform, he gets a different price. It's cheaper if he goes through Estação do Olho. So he gets more access. It's easier for them to pay, okay? For the exam, not for the screening, okay? We believe that uh, stimulating people to get free scanning, we are going to be able to educate the people, and so they are more aware of eye diseases and the frequency that they have to go and see an eye doctor. And by doing so, we're going to be able to identify a lot of diseases in the right stage. And for that, we use the VX, like I said, VX 650, which is a multimodal diagnostic device. It's very user friendly and it's very suitable for mass screenings like we're doing. And it's very quick and it's non-invasive, so we can have technicians. We don't have to touch patients. We don't have to put any eye drops. So it gives a lot of patients comfort. So it's very, very practical. In the VX 650, it combines powerful tools like wavefront, Shackman Hartman, so we can get very accurate auto refraction and also aberrometry of the eye. We have this Placido ring-based topographer. We have a shine fluid camera that enables us to do pachymetry and see the AC angle. We have this non-mediatric fundus camera. We have this air tonometer and external camera. So with all this technology combined in one single equipment, we are able to do a fast and very accurate screening, and we can detect a lot of pretty much all the major eye pathologies like refractive errors. We can see with the external camera conjunctival and eyelid lesions. With the topographer, we can see keratoconus. Also, the shine fluid helps with the pachymetry and cataracts with the retroillumination camera and the aberrometry. Also, glaucoma, nevi in the fundus, hypertensive and diabetic retinopathy, and much more. I think it's a very comprehensive machine that can pretty much scan for most of the diseases. Of course, I don't think it's going to substitute the professional, the eye care professional, but it's a very powerful tool. And here, before I started the project, I had the VX 650 in my office, and I needed no training. I was able to train myself, since I had some previous experience with other equipment. But when I started with the project, I went there and I trained the 3 technicians that I have myself, and I was able to train them in about a week or less than that. And an interesting thing is that after we had more than 3 technicians, and now I don't have to go there anymore. They are able to train themselves with minimal training. And if we have all the registration, the visual acuity check, and the screening, it takes about 10 minutes for a patient. Okay, we have now, as we speak, we have screened almost 4,000 patients, but my presentation, I used the data from the first 3 months, so about 2,000 patients, and we have an average about 30 patients daily. So we are able to get the machine working about 10 hours a day and with no further issues. So after we do the registration, we have a health questionnaire. And with this questionnaire, we are able to assess a lot of information, which includes demographics, economic status, family history of eye diseases, ocular diseases of the patient, systemic conditions associated, and much more. This all together with the reports that we have in the VX 650, we are able to make a very, very thorough risk assessment. And after we scan the patient, the VX 650 give us a report that you can personalize, and you can export this report in various ways. So we export this to our data center where trained ophthalmologists, they read the reports and they combine the information with the questionnaire and they come out with a risk assessment for the patients. Nowadays, we're still asking 24 hours to release this risk assessment that the patient is going to be able to get online in our platform. And it's very nice because we point out for the patients the risks, and at the same time we give them like a handout that tells the frequency that they have to see the ophthalmologist, the diseases that are more prevalent for the age group. So we start educating the patients. And this is some numbers of our project. Like I said, this is the first 3 month preliminary data. We're still gathering more data, and it's going very well. And we were able to assess a few data, like I'm showing you, a little slightly more women. And it's important that we see that about 65% have no health insurance. So that means less access to health professionals, eye cares. And in Brazil, we have a very mixed racial profile, so it shows here. But interestingly, we were able to see that at least 3/4 of the patients, they have one or more abnormal finding. Okay, that's a lot. And that through the questionnaire, we were able to identify about 8% of risks factors for eye diseases. But about 14% had no significant findings, and 1.2 were inconclusive. What that means, and it's nice to see the graphic, because you see that at the beginning you have more inconclusive exams, but as the technicians they got better, and that was very fast, we were able to increase the screening quality, and we were getting much less inconclusive tests. Okay, this is a nice number, and I think that shows the importance of this project, because which is prevent and educate and give access to health. So we were able to see that about 12% of the patients, they never had an eye exam before. And we are putting together in a scientific paper this data, and we have seen a lot of diseases that the patients they were not even aware of. So that's the importance. to get the patients, identify, connect them, and educate them so they can they can be eye care providers in a certain way. They can communicate with their community. They can increase awareness, and that's very education is key for prevention. So some results. The majority of the cases had some refractive errors, about 75%. We had some patients with loss in visual acuity, which we consider last vision worse than 20/30. And also we were able to see that 16% had pressure, intraocular pressure over 21, some changes in topography in 16%, asymmetry in ocular pressure, retinal abnormalities in about 7%, some corneal thinning. We are able to see the AC with a narrow angle, shallow anterior chamber, conjunctival lesions, and a lot of other abnormalities only using the VX 650. So I'm going to go for real cases. Let's start with incorrect refractive errors. So this showcases a patient, 36-year-old patient. He was never seen by an eye doctor, and his visions, because people, they don't have a comparison to do. So he was walking around with 20/100 vision in the right eye and 24. That was normal for him. That was real life, and he didn't even realize that the vision was not good. But he had some moderate astigmatism, which probably was responsible for the decrease in visual acuity. We can see that the topographies are pretty much normal. He has some regular and symmetric astigmatism, and the fundus pictures are also normal. So this patient is going to see an eye doctor. He's going to get glasses, and he's going to see the 20/20 vision, and it's going to improve his quality of life, his productivity. Everything is going to get better. We can also, it's very important, screening for glaucoma, and we are partnering with societies so we can do campaigns, so we can get to screen patients in a scale that we are going to be able to increase the diagnosis of glaucoma. And here to showcase, we have two cases. One is a 20-year-old patient with glaucoma already. He had mild decrease in vision, but we can see that the pressure here, as we can point out here, it's elevated. It's over 21. So if you have a glaucoma suspect or a glaucoma patient, you want to have the IOP lower than this. And we get to see that he has some increase in cup disc ratio. So probably this patient should see his doctor and adjust his medications. Okay, so that's important. And on the right side, we have that's even more important. We have a 49-year-old patient without history of glaucoma. So he doesn't know he has glaucoma. He has decrease in visual, both eyes, and look at the pressures, 21 and 32. Okay, so when we look at the fundus picture, they are very good quality. That's one thing, and we get to see that the cup disc ratio, it's increased, especially in the left eye. So that's very important because we have to send this patient to go and see a glaucoma specialist, because if he doesn't treat depression with some drugs, probably he's gonna end up blind. And I've seen that happens a lot of time. I've seen patients in the 70s, 80s discovering that they have glaucoma, and then they are blind already. So that's very important to foresee and to prevent. So this is another case, which is I've seen a few cases in my daily practice. So this patient, he has a very shallow, with the shine through camera we can see, has a very shallow AC, anterior chamber, and the narrow angle. So this patient is at risk of an acute angle closure glaucoma. So this patient is a good candidate, at least for to perform a peripheral iridotomy with laser. This could save. I've seen patients with acute angle glaucoma crisis, and they going blind. They decompensate the cornea, and that's a mess. This patient, he still have good discs, so let's prevent something worse. So that's another very good example that pathologies that we can anticipate and treat. Here in my area of expertise, since I'm a cornea specialist, this is a 27-year-old patient, no history of keratoconus, so he didn't know he had keratoconus. Keratoconus is a progressive disease of the cornea where the cornea it's deeper and it's thinner. So here, a patient that only had mild decrease in visual acuity in the right eye, but here the topography we can see some irregular and asymmetric astigmatism. Also, we can see the cornea, it's thinner than the normal range. So this patient has keratoconus, and it's very important for him to see a cornea specialist so he can follow up, and if he continues to progress, he's going to be a candidate for corneal cross-linking, which can halt the progression of the disease. And by doing so, you change the natural history of the disease. So this patient can wear spectacles. If we don't follow him, if he don't follow up and he progresses, he's going to end up needing a corneal transplant. So that's a very good example of how the early detection is key for maintaining a good visual acuity. Also, retinopathies. Since you don't need to dilate the patients, you can use this, the technicians can use this, you can do telemedicine, and you don't need to put eye drops. And we were able to capture a lot of changes, about 8% of the patients with some abnormalities in the retina. In the left side, we have a diabetic patient with mild decrease in visual acuity. You can see some changes in the fundus. You can see exudates. We can see sometimes microaneurysm, some edema, hemorrhages. In this case, we have to check the pressure as well. This other patient in the right, you can see some exudates in the macula over here. You can also see some AV pathological crossing in this right picture over here. So if you follow up those patients, sometimes, like we said, the eye is the window of the soul. If you're able to screen patients and see those abnormalities in the fundus, especially for diabetic patients, if you have a bad retinopathy, that means that you have bad kidneys, you have bad circulation, and you have to treat this patient a little bit better. Also, we can scan our children, and that's very important because they have the whole life ahead of them, so we need to be very careful with them. And in our screening station, we recommend patients over 5 years old because we do need some cooperation to do the scanning. We have scanned younger patients, but you don't get very good quality if he's not cooperative. So in this example, we have this 10-year-old patient that has never been seen by the eye care, and you can see has 20/60 of visual acuity in both eyes. So maybe this patient is not going well in the school. Maybe this patient has a bad behavior that people are thinking that he's just a bad kid, but maybe he's not seeing well. That's why he's not concentrating on school. Maybe that's why he's not having good grades. So if he goes to an eye doctor at the right time, and he's going to be able to get the spectacles and have great vision. So those are a few cases that I wanted to show you that we can use the VX 650 in daily basis with very good applications. We still have a lot of challenges, and we have learned a lot from the project, but we have a few gaps still. Awareness. People, they are not educated about screening stations. They are not educated about routine eye checks, even other checks that they had health and that they have to say, but we are trying to expand our reach through social media. We are collaborating with some other social projects. So we want to screen, identify, connect, and prevent something that can makes the patient go blind. Okay, and we want to educate the population because, like I said before, if you educate one person, he can educate more more other people in the community, and that's going to be very important for prevention of blinding diseases. Sometimes we have a lot of patients in the station, and that makes a little bit of jam. But we are trying to, as we validate our station and the business model, we want to expand to more and more stations with more staff, so we can screen more people. And one problem that we still face is that this social class that we are aiming for, they still have some difficulty with digital media. The younger patients know, but older patients, they don't deal that well with digital platforms to get the reports, to schedule the appointment. So we are trying um, to facilitate our communication, and we are trying to make all the patient's journey as simple as possible. We are changing a few things in our business model, and I think we're gonna get there eventually. Let's hope so. And it's very hard to follow up the patients because we have a call center that we actively go. We wait for the patients to find a partner, a ophthalmologist, but we also go after them. The ones that we see that they have severe changes, we try to reach them, but sometimes we try to call, we text message, we send email, but we don't have an answer back. And that's frustrating. And when you identify a pathology, you cannot direct this patient to the right professional. But we are trying to find ways to to go after the patient. We have CRM strategies to reach out for those patients as well. And we are still early stage project, so we still have some funding issues, but we are getting there. We are doing the right partnerships, and we are collaborating with a lot of people. And I think people are increasing their awareness about social projects like ours. And it's the first one of this kind here in Brazil. So, and we already had some investors looking, and we had already two angel investors putting some money in the project, but we are planning to do another round soon so we can expand. So it's, I hope it goes well. For future directions, of course, we think about the expansion. We have plans to put more stations, not only in Rio de Janeiro, but other states, because if we put more stations all over Brazil, we're going to be able to screen much more patients. We're going to be able to do a map of the eye diseases, and we're going to be able even to collaborate with the public health system to try to find strategies to better serve the population and to better give access to them. Um, of course, we are planning to develop and integrate some artificial intelligence in the process, so we can have pretty much instant report. So patient leaves the station with the report. We want to use the AR to not only to speed up the report time, but the risk assessment time, but also to even to predict some diseases and progression, and to integrate and help us to analyze all the data that we are collecting. But we are getting there, and I think we have the AI is developing so fast that where we've been having a few conversations with people that work with AI, and they're very promising. And of course, collaboration, because it's a win-win project. Everyone that gets involved can make something out of it, something good, because it's like chain a good, it's something good. That patient gets involved, they get prevention, they get accessibility. The doctors, they get patients and they help patients. The industry, they help patients, they increase the awareness of brand awareness. So by integrating and collaborating with everyone, I think we can make this happen, and that's very important for the project. And in conclusion, since we're talking about the VX 650, I think it's a great piece of equipment. I think nowadays to have, we know that ophthalmology apparel and equipments, they're very expensive. So if you try to buy 10 equipment, you're going to end up working your whole life for paying that. So if you have one machine that can combine with quality or a lot of different scanning modalities, it's perfect. So you can use uh, with, you don't need to highly trained personnel. You can do telemedicine. It's a very intuitive equipment. We have good assistance. It's a remote. So I'm very happy with the use of that in my project. And it's very effective as a screening tool, especially when you integrate with remote reading center. Sorry. And since I said it's a powerful tool with a lot of modalities that can detect a broad range of abnormalities in both anterior segment and both posterior segment of the eye. And that's it. Thank you very much. I hope I didn't go too fast. Now we're going to be open for a few questions, suggestions,
Yeah,
discussion,
thank you very much,
anything
Doctor,
that
for
you
this
guys
very
would
insightful
like
presentation,
to ask me
which
or
actually
suggest.
emphasized the crucial importance of multimodal platform in early detection and prevention of vision loss. So yeah, to your point, it's time for a Q&A session. I see that we have already a couple of questions in our chat. So I will start with this one. How can we improve patient follow-up rates after abnormal findings are detected in screenings, particularly in underserved communities?
Hi, Jonathan. Thank you all for your patience to stay into the end. And I think it's I have here my partner and my business partner Bruno. His Gustavo, but he's Bruno. He's my co-founder, and I think answering the question of Jonathan, follow up, it's crucial because it's not enough to identify the abnormalities, but we have to try to do our best to reach out for those patients and try to connect them to the ophthalmologist so they can have proper diagnosis and treatment. And of course, we have some strategies. Like I said in the presentation, we have a call center that we try to reach out for the patients. We have a CRM strategies, so we keep in touch with the patient, educating the patient in regular basis. Also, we have a kind of a concierge that it's open. It's a open line, telephone line for questions and doubts for that patients have. And we also try to keep in touch with our network of physicians. So they give us feedbacks about the patients, and they give feedbacks how we can improve and reach out for the patients. I don't know if Bruno has anything to add.
No, no, actually, you pretty much summarized it all, right? So we thought like a passive strategy would be enough in the beginning, a conversion funnel, so they would just click and be connected with one of our partners. But conversion rates were not ideal, so then now we are going more into an active pursuit of those people, and then encourage them like to see doctors, particularly the ones that we were able to identify a finding in their exams that need to be seen.
Okay, thank you very much to both of you. Another question, what role can emerging AI technologies play in enhancing the diagnostic accuracy and efficiency of the Visionix VX650 in future mass screenings?
I think, Jonathan, that of course AI it's developing real fast right now. We are living a great moment for AI, and of course we are thinking about integrate more and more AI in our protocols because that's the future. Like I said, we are early stage company, so we are trying to balance our investments. So we do the right steps at the time. But I do believe AI is going to be a game changer because we're going to be able to speed a lot the reports, maybe real-time reports for the patients. We're going to be able to, through the data and analytics, we're going to be able to personalize patient orientations. I think we're going to be able to, with AI, to organize better and to analyze our data, like I said, optimize patient education. Even we have a lot of tools that can help us to predict a lot of progression of the diseases and even correlate eye diseases with systemic diseases like Alzheimer's, for instance. And so it's a broad field, and I believe it's going to be very excited and it's going to be happening very soon.
And another thing else that adds to the challenge, like it's a multimodal equipment, right? So we don't have only one exam. It's not just one retinal image. We're definitely not trying to detect only one disease. So there's only a lot of models there, like for example, to detect diabetic retinopathy, but that would be, just a fraction of the diseases that we identify. So of course, we need a workflow, but we also need like several models to analyze each of the points that we detect in our patients. And so it's not just one AI model, it's probably like 12. So it adds a bit the complexity, but like, I mean, at the end, like we will be able to give like a very comprehensive report, like for each patient, like almost instantaneously.
Great.
Okay. Thank you very much. Couple of other questions. One from Paul Villan, which is how do you make visual acuity with iRefract or manually?
Now we have it's kind of manually. We have a screen, a 32-inch screen, and we measure the visual acuity with correction. Okay, if the patient's wearing contact lenses, we ask patients to come back another day because it's going to interfere in the screening. But usually we try with glasses, and we see the best correct visions in the Snelling chart, the portable one. It's manually.
Another one, I have two other questions. So, what strategies could be implemented to increase public awareness about the availability and importance of eye screening services, which are actually provided by the Estação do Olho projects?
Okay. Yeah, I think it's great because I hope that more and more projects like ours they go out to real life because I think we need to create awareness and some strategies. Of course, nowadays we have to be very active in social media and try to put a lot of educational material other than just uh, regular marketing. And I think we are working a lot to try to do scientific papers, so it gives us more credibility, credit, so we can show that we are a serious company. We are trying to put together at least once every semester like social campaigns where we can do for example, we are about to do a campaign with children from 6 to 17 years old. We're going to be able to scream and get the eye check and the glasses. So through those campaigns we are able to create more awareness, and of course collaboration is key. Every good project has to have a lot of collaboration. So we are trying to reach out for government so we can increase some programs in ophthalmology field. We are also trying to partner with the societies, ophthalmology societies, so we can try to maybe do the campaigns that they regularly do, we are trying to do through our station. So we have a lot of data, and we already have this hub, so it's easier to do the campaigns through this station. We can collaborate with schools and of course with big companies because they have the resources that can help us out with expansion, and I think that's gonna be a good strategy to create more and more awareness.
And I'd like to add also, like I believe the best tool we have for awareness is the station itself. Like
Yeah.
it's a beautiful station. We intentionally placed it in like a high traffic location. It's one of the largest malls in Rio. There's a metro station right in it, so a lot of people pass right in front of it like every day. They need to get out of their way like to see the station, and they have their eyes checked. Because there was another thing that we noticed like after we started doing the project, like convenience is key. Right? So like if they need to get out of their way to have their eyes checked, like probably they're gonna push it to another day, and that will never happen. But if they're there already, like they're passing, takes 10 minutes of their time, it will happen. And then like once we send the report to them, it's like, look, there's something wrong with your eyes. You gotta check. So now they have a motivation to actually go and call an ophthalmologist, book an appointment, and like take care of their eye health.
Get
That's
it.
it.
Yeah, thank you very much. I have a very last one question, which are actually are two questions. Did you use the VX650 built-in AI analysis for fundus photos? And do you have any conclusions about how well it matched with the ophthalmologist analysis?
Mhm. No, we didn't. We did not use this integration. I've been talking to Fabiano, which is the Latin America representative of Visionix, and we are trying to that's in the future directions because, like I said before, we were trying to first put the project out and try to test a few hypotheses, and as we go through, that's the next step, and we are having very good conversations with Visionix, and probably I think you guys are very good partners, so probably it's gonna happen soon. Okay, and so that's it. We are not using yet, but that's gonna happen soon.
Yeah, and then even though AI tools will greatly add value, to the whole chain and make our jobs a lot easier, we wanted to do things manually in the beginning, just to make sure that the flow works great, and we were able to have an idea what the kind of diseases that we're more likely to identify, and also eventually like have the flow, the diagnostic flow that will be used to train like the model that we're going to use after. AIs I like pretty much like computer softwares, right? Like they need to be trained, they need to be coached. Like so, if we didn't know, like I mean, what are we dealing with? Like we don't think that AI would do a great job either. So it's a lot of work. We kind of like screened over 3,000 people already, but it's a necessary step. Like we need to have a great team in the future.
Yeah, that's great. Okay, thank you very much both for your answer on that. So thank you, Dr. Novais. Thank you,
You're
Dr.
welcome.
Fernandez. That I believe that was a great session. So thank you very much for all your explanation about your project. I think it was very insightful again. And once again, I would like also to thank all the people who have been attending this webinar. So stay tuned actually for the next session. Stay connected on visionix.com, and we'll be happy to share. Thank you very much.
Thank you all.
Everyone, have
Bye,
a good night.
doctors.
Bye bye.